Hello, welcome to this week's concept map presentation, Approach to a Patient with Dizziness. Please bear in mind that these presentations will not cover the pathology and management of each condition, but rather the identification of it. Dizziness is a common complaint in patients, and evaluating the dizzy patient can be challenging since it is a non-specific symptom and there are many causes behind dizziness. Two studies performed approximately 30 years apart have confirmed that there are four general subtypes of dizziness: vertigo, near syncope, disequilibrium, and psychophysiologic dizziness. So, the history provided by the patient or witnesses is the most important source of information in the evaluation of the patient. What do they mean by dizziness? Patients usually describe vertigo as if the room is spinning, descending in a lift, tilting or somersaulting. Patients with near syncope generally say they feel like they're going to faint. Patients with disequilibrium describe their dizziness as if they are going to fall or that they feel unsteady on their feet. Patients with ill-defined dizziness say that they have left their own body or that they are floating and swimming. Some patients describe a spinning sensation inside their head. Unlike vertigo, this is not associated with an illusion of motion. An approach to a patient with vertigo, syncope, and disequilibrium have already been released in the last few weeks as separate topics, so it will be easier for you to find them in this programme and also give you a chance to build up the knowledge gradually. Today, we will put them together as Approach to a Patient with Dizziness. Vertigo is defined as an illusion of motion, and if someone presents with vertigo, it is very important to distinguish central or peripheral. Their presentation is slightly different. If the patient presents with any of the CNS symptoms, such as dysarthria, diplopia, abnormal gait, weakness, incoordination, or central nervous system signs like cranial nerve abnormalities, ataxia, positive Romberg, abnormal nystagmus, we consider this central vertigo. If the patient has no CNS signs nor symptoms, the symptoms are more likely to be peripheral vertigo. We look at the duration of the attack and other associated symptoms. This slide summarizes how to differentiate the different causes of peripheral vertigo. I hope that this helps you. It is important to realize, however, that a person may describe more than one subtype, but rarely describes elements of all four. Next is to look at how we approach if they describe as nearly fainting. Near syncope is due to a global reduction of blood flow to the brain. If history clearly suggests as environmental factors, history of pain, anxiety, cough, occurring while standing, preceding nausea, rubbery legs, diaphoresis, and constriction of visual field, these warning signs are the body's way of signaling that the person should lie down. If the patient is unable to lie down, she may progress from near syncope to syncope. Orthostatic hypotension, cardiac disease, and hyperventilation can also present as nearly fainting. If the patient describes their dizziness as near syncope, evaluate syncope. If the patient describes as vertigo, distinguish central versus peripheral. Or if the patient describes as imbalance, evaluate the cerebellum, posterior column, and peripheral nerves. If it is a normal gait, consider multiple sensory deficits. Stocking glove sensory deficits are typical of diabetes neuropathy. If the gait is abnormal and wide-based gait, consider cerebellar disease. If the gait is abnormal and shuffling, consider Parkinsonism disease and look out for the other signs of Parkinson disease. The next crossroad is to look at cerebellum and its input like vision, eye test, vestibular system examination, check rapid eyes movement, coordination tests to confirm or exclude cerebellum lesion. The loss of proprioception suggests posterior column disease. Confirm with Romberg test, check B12 level and FTA antibodies for syphilis for tabes dorsalis myelopathy. If the patient describes as ill-defined lightheadedness, general weakness, evaluate medications, systematic review, and psychiatric history. For every symptom, there might be the cases that can mimic a less serious diagnosis and lead to missing a life-threatening condition. Please carefully double-check to identify and rule out life-threatening causes. Here is the concept map for assessing patients presenting with dizziness. Here is another example of approach to a patient with dizziness. Using these examples, read some symptoms to diagnosis books and create your own concept map for each symptom. This presentation's purpose is to guide your thinking process when you encounter a person with dizziness. This presentation is not meant to be a tool that you use to diagnose your patients with. You will need to exercise clinical judgment and consider the clinical context of your patient's presentation to make an accurate diagnosis. Thank you very much for listening.